Good afternoon, everyone, and welcome to the seventh session of the UGLO Open University sessions. As you probably know, our online lectures are related to global health, and in today's session, the focus will be on social and economic determinants of health. An important disclaimer for you that you're probably already familiar with. If you have any questions to our panelist for today, you can write them in the comments below, and we will be holding a short dedicated Q&A session for you at the end. So right now, I would like to introduce our speaker for today. So huge welcome for Martin Stafström, who is an associate professor and senior lecturer in public health at the Division of Social Medicine and Global Health at Lund University. His main research area is community-based health promotion, specifically among young people. He has also been involved in several research projects studying the relationship between social determinants and lifestyle diseases, such as obesity, stroke, and alcohol use in a variety of geographical settings, such as Europe, Latin America, Africa, and Asia. He is the former program director of Lund University's MPH program and has been leading several courses in global health. So, without further ado, Martin, I will give the floor to you.
Yeah, my name is Martin, and well, I think Susanna gave an excellent introduction. I wonder why. But today we're going to talk about the social determinants of health. And to start off, I would like to show you this picture. Because health, we often relate to medicine. You get sick. You go to a doctor, you get some kind of drug, and hopefully you stop being sick. But in public health, we're often quite interested in why people get sick, because, I mean, the ultimate goal is that nobody should get sick. And what we found is that there are domains outside the field of medicine that play an immense role in affecting people's health, such as education, equity, which is fair distribution of things in society, demography, and economy. And we're going to look a bit closer on these things during this lecture. So first, I would like to do this so-called rainbow model. And it was published by WHO in 1991 by Dahlgren and Whitehead. And what it tries to show us is that health is affected by different things around us. So in the middle, in the big red bubble, where it says age, sex, and constitutional factors, we have things we cannot really change. Age, we are the age we are, no matter plastic surgery or cryonics or whatever, we are the age we are. Same goes with biological sex. That's not much we can do about it, or genetic setup. We're trying to figure out ways to deal with that, but we're still not there quite yet. So nevertheless, that's who we are. But we are affected by different things. We are affected, if we go to the top, by the general socioeconomic, cultural, and environmental conditions we live in. For example, we have different health challenges in Northern Europe than we have by the equator, just by climate. It's a fact that it's hot, humid around the equator, whereas it's dry and cold and quite dark, to be honest, in Northern Europe. And that makes us prone to different types of health problems. Malaria can't exist in Scandinavia, where I live, and thankfully not in Hungary at the moment either. Whereas in Uganda and Rwanda, where I've been working, more or less everybody has malaria. Then we have general socioeconomic conditions that are also quite difficult to deal with in the short term. Things like if I live in a wealthy country or in a poor country, that will affect, for example, infrastructure, educational systems, what kind of labor market there is, etc. We have cultures that affects our lives. Alcohol misuse is not very common in Saudi Arabia because it's a Muslim country where alcohol is not permitted. Whereas in Eastern Europe or Scandinavia, alcohol problems are quite common if we compare to other places in the world, because there is a long cultural tradition to consume alcohol. So these factors do play an important role. Then we have what's called living and working conditions below that, which are somewhat affected by the general socioeconomic, cultural, environmental conditions. Here we can see what food we eat. Agriculture is affected very much by climate, but also it's just by the name of it, agriculture is an important cultural phenomenon. I was involved in one project in Africa where we tried to, I was part of the evaluation, so I wasn't part of the intervention, but the idea was to implement a new type of cassava which contained more vitamins than the traditional cassava. The problem was that these vitamins meant that the cassava, instead of being purely white, was almost a little bit orange. Not as much as carrots, but a little bit. So people wouldn't eat it. Not even if they knew it was more healthy, because cassava should be white. So culture is a difficult thing to affect. Education is another thing that affects health in many ways, and we'll get into that much more in this lecture. The work environment. Is there regulations or not regarding work environment? Do we at all consider psychosocial work environment as an issue or not? Are there legislation, etc., that makes it difficult for employers to have a very poor work environment? The degree of unemployment is very important. We know that countries with high degrees of unemployment are struggling with health even among the richer people for different reasons, and we'll get into those as well. Water and sanitation, extremely important to when it comes, for example, to child health, requires investment in infrastructure. So if you live in a country that is poor, those investments are usually not there. And the same goes with healthcare services. Financing a healthcare system is expensive. So there need to be funds doing that. And if you are in a poor country, there are no funds. Housing is also very important. Living conditions, where we spend our time. Is there good ventilation? How do we cook and prepare our food? Is there light? Is it cramped or not? Is it 10 people living in one bedroom, or is it one person living in 10 bedrooms? Will affect health. Then in the yellow sphere, we have social and community networks. And that is that we know that we humans are, in general, social individuals. And that means that we have something called social capital. And the social capital is part, it's our social networks, and part, it's the trust we have in other people. And if we have a lot of that, we can use that when we're making life decisions, because many of our life decisions are impossible to make on your own. For example, what kind of pension fund should I put my money in? You need to discuss these things. And for countries who have private health insurance systems, same thing there. You need to discuss these things with people who will give you input in order for you to make a better decision. It doesn't only have to be pension and the healthcare. It can be whether I should take the bike to work or not. It could be whether I should have a vacation lying by the pool drinking margaritas or a vacation climbing a mountain, which will also in the long run affect your health. And then we have the individual lifestyle factors, and that is how we as individuals interact with our community. And we as individuals, for example, have a certain level of education. We have certain access to water and sanitation, to take a few examples. And it is how we interact with those resources we actually do have. Because, of course, you can do that in good or bad ways. So, all of this affects health, not only age and sex. Now, demography. Demography is important because it has a great impact on how countries are financing the whole health system, but not only the health system, the whole social sphere. And what's important when we talk about demography is to understand this. This may be a difficult thing to understand if you've never seen it. And this is called transitions. And we've jammed two different transitions into this. We've jammed the red line in there, which is called the demographic transition. And then we have the green field, where it says natural increase in the middle, which one could call the epidemiological transition. And that's actually the black line more than the yellow, more than the green field. Now, if we think about world history going back to the Stone Age, maybe even a bit further ahead, we were in what's called the high stationary cycle or phase, where we had high death rates, but we had also high birth rates, and we had a very small population. There was a small increase in population, and that's why there is a thin green area between death rate and birth rate at the top. Now, what happens is that in the early expanding phase, we start to be able to improve things to get the death rate down. And the most important things that happen are the smallpox vaccine. It's in diet. The potato has been extremely important because it added a variation to the carbohydrates we as people in Europe, if we take Europe as an example, consumed. So used to be only one thing, and with potatoes, it was now several types of carbohydrates that came in. And the good thing with the potato was that it was a bit production-wise was quite good. Was a bit safer than other stuff we had. Now, then we go, and what happens is that the birth rate remains quite high. So what we get is a very big natural increase of population. And this continues up through the so-called late expanding. And here we are suddenly discovering, for example, bacteria. We are discovering virus. We are doing other big breakthroughs in medicine, which then leads to a further drop in the death rate. But now we also go into the Industrial Revolution or really to the latter parts of the Industrial Revolution. With that lower death rate, we also get a lower birth rate, meaning that the natural increase of the population are diminishing. Then we go into stage 4, which somebody calls modernity, which is pretty much, let's say, post World War I and up until late 80s in most of Europe, where the birth rate is decreasing even more, and suddenly we reach a point where we don't have any population increase whatsoever. And now most of Europe, at least, North America definitely also, Australia, New Zealand, now we're in a phase which is more phase 5, which is the declining phase, where we have a natural decrease of population. And I know in Hungary, there is family policies that are trying to encourage your generation to be a bit more productive in the bedroom, if you excuse that term. But the idea is, of course, that every mother statistically needs to have 2.1 babies. Otherwise, we have a natural decrease. And no country in Europe actually achieves that today. The lowest birth rates are in Mediterranean countries, and the highest ones are actually in Sweden, or one of the higher ones. Mostly because we have had family policies which are very generous to parents for the past 30, 40 years. And it seems like if we want to promote rather than force, which is a Chinese approach to it, family planning, then it takes a while to happen. The big bump in Swedish birth rate came around 2000. So, and family planning policies started to take off in the beginning of the 70s. So it was more or less 30 years until the effects became evident and clear. Now, depending on which stage you're in, you are also in different demographic situations. So if we have high birth rates, high death rates, then we have a demographic pyramid, which is very much a pyramid. And the same goes for stage 2, the expanding one, meaning that we have a very small old population and we have a very big young population. And the productive age, which is 15 to 65, where people actually work, pay tax, and don't cost that much to society, is quite small. And in stage 3 and stage 4, that particular portion of society is quite big. In stage 4 and even stage 5, we have a very small young population. And eventually, the older population will grow even bigger. So we will have a smaller portion of productive people. And this is important not only because talking about tax policies, etc., but it's also very important because we do have different health problems at different ages. So if we have a very large elderly population, we will have a lot of health problems that are associated with old age. And if we have a very young population, we will have health problems more associated with that. So that is why it's very important when we are thinking about public health that we all start with what kind of population do we have. I remember in the beginning of the COVID pandemic, one thing that was discussed, at least up in Scandinavia, was that Why did so many people die in Italy? And one thing that popped up was that northern Italy has a rather old population. And as COVID was far more lethal to older people, that was an explanation that was used. Another important thing, if we talk about global health, is to understand that the world is not very equal. Past years, we talked about development and development countries and developed countries. The problem is that all countries need development. There is no country that is fully developed. So it's a bizarre term to use. And what we can see, and this is from the World Bank, is that there are definitely income differences that determines the health of countries. So we have low-income countries, which is about $2 per day. That's the per capita income. And then we have high-income countries where it's $10,000 per day, which is more than 10 times richer than the low-income countries. So it's a great span, and I mean there are countries with GNP per capita, which is around 50,000 US dollars. So within high-income countries, there is a very wide span, but health-wise, the span isn't that wide. Health and economy is important because health is actually in economy, the field of economy or the subject of economy. Health is defined as productivity in all fields, meaning that if you are productive, you are healthy. Now, we know that economy finances health directly and indirectly, in the sense that a direct version of economy financing health is, for example, to make sure that there are hospitals and there are a health system in place. But we also know that rich people tend to live longer than poor people. And it's not because the country provides more health care to rich people than to poor people. It's because with money, you have the possibility to make life choices that it's difficult to do if you don't have money. You can take, for example, what food you put on the table, or whether you can afford to buy a bike, or whether you can afford to go for a run in the afternoon instead of working. Those kind of things is also important to understand when it comes to the relationship between economy and health. But it's also important to understand that health is an asset that governments can choose to invest in or not. There are good examples of, let's say, Cuba, a very rather poor country, but have most doctors per capita and have the same life expectancy as the US, more or less. But is much, much poorer than the US because the US government has decided not to invest a lot in health. There are worse examples than the US, but it's a common one. Now, there is this notion that if we have economic growth, then we will have a healthier society. But it's not the full story. We need other things as well as economic growth. It's important, it really is, but There are a few things we need to have in combination with economic growth. So, for example, we need a healthy and educated population. So, you cannot just go for money, 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 money. You also need to invest, for example, in education systems if you want to also achieve good health. Public institutions needs to be good. We need to have a well-functioning police. We need to have a well-functioning legal system. We have to have well-functioning tax authorities. If people are not paying their taxes, then we can't use the additional economic growth in a good way. We also need civil society. We need governments that collaborates with civil society to improve the lives of everyone. With civil society are, for example, trade unions, religious organizations, sports clubs, interest groups, for example, important, for example, for healthcare systems is patient groups. That we know that healthcare systems that collaborate with patient groups often deliver higher quality of healthcare because we need to be in a dialogue between the healthcare system and the users in order to understand how can we be effective in delivering high quality care. And also important is good governance. We need to rule in the interest of the majority without corruption. Shouldn't be that some minority in society uh, is ruling for everybody else. But at the same time, good governance is also to rule in the interest of everyone. Um, and importantly, we need a system that is not corrupt, where people who are rich, for example, can buy themselves better service. Or if you're a friend with the right guy, you suddenly get better healthcare. Um, that is not good governance. So we need these four things as well, apart from just economic growth, for health to really thrive. Now, usually when we talk about social determinants, what we actually think about is not fixed social and economic conditions which we live in. Meaning not fixed is that it's not decided by some uh, divine intervention or something that people who are poor should be poor forever, etc. So it's things that can be altered. And normally, when we talk about social and economic conditions, we talk about housing, talk about living environments, we talk about access to health services, access to education, and professions. What type of work do people do? Um, now, social determinants of health are important because they contribute to health inequalities between different social groups, and normally due to unequal or unfair distribution or access. So, for example, is it as easy to access high quality healthcare for everyone in your country? Um, the answer is simple, it's definitely no. There is no country that has a good solution to this. But it could be because of different reasons. It doesn't have to be that it's the system that is to be blamed, or, well, in one way it is, but they're trying their best. It's just that they're not trying hard enough, or they're not trying with the right measures. So often we need to understand how the relationship between the health system and the users actually functions. And in Sweden, for example, we know that immigrant groups are not accessing healthcare the same way that non-immigrant groups are, for different reasons. And the COVID pandemic has actually meant that we have learned a lot regarding that, especially when it came to vaccination, where we understand that the way the healthcare system has communicated with most people has been quite effective, but for many immigrant groups, it has been very ineffective because it has triggered the wrong sentiments. Just as with economy, social determinants of health influence health both directly and indirectly. For example, dangerous jobs, or whether you have access to green spaces, or access to well, housing conditions, for example, whether those are healthy or unhealthy for people. But indirectly, they are that's kind of the main thing with social determinants of health. That it's usually not a direct connection. Usually, it is that, for example, we know educated people have better health than others, but it's not like education per se affects your health. A university degree won't save you from getting cancer in the future. It's the way you live your life that decreases the risk for cancer. But still, well-educated people have less cancer than less educated people. Social determinants of health are often interconnected, meaning that if you have low education, you probably have a lower income. If you have lower income, you probably have poorer housing, etc. Social determinants operate at different levels. The ecological rainbow model is what I'm referring to, that it's both at the top level, but it's also on the mid levels and further down. Social determinants are there all the way. And as I said before, when we have, as the different social determinants are interacting with each other, and means that you get accumulated challenge with these different social determinants. So if you have just a little poverty, you will have just a little poor housing, little unemployment, inadequate food and nutrition, lack of education, environmental health hazards, etc. So the slope will be very low. But if you have a lot of poverty, you will have a lot of poor housing, etc., etc., and the slope will be very, very steep. Typical image of the social gradient and health inequalities are these kind of plots where we can show that the bottom 1%, this is the US, the bottom 1% income-wise, men have a life expectancy of about 75 years, whereas the richest 1% in the US has a life expectancy of almost 90. So there is almost 15 years difference in life expectancy if we take the compare the poorest with the richest males in the US, and the difference among women is about 10. Males have lower life expectancy than women, and it's basically well, it's different things, but basically males have more work-related health hazards. There is more violence is another one. Alcohol use is another big one, and smoking is usually more prevalent among men. So those are the main drivers of the difference between men and women and in life expectancy. Health equity is an important factor, and here is just one part of it, and that is financial access to healthcare, where, and these are different healthcare insurance systems. The Swedish one, um, an American one, the German one, and Star is, I think, Australian. But we form in all of our countries around the globe, we have different ways of financing the healthcare. In most parts of the world, it's out-of-pocket payment. You go to the doctor and you pay the doctor when you're there, and you pay the full cost of the doctor seeing the doctor. That's actually what we can see in most of the world. If we take the rich part of the world, let's say EU countries, there is very little co-payment because most of us are paying through our taxes or mandatory fees that are put on salaries. Because the more we cope, the more a healthcare system is financed through some kind of collective means, it's actually pushing down costs for everyone, including the healthcare system. So it's important to understand that healthcare systems are you can finance them in many different ways. You don't have to finance it the American way, or you shouldn't, because that's the worst way. They pay more and their costs are higher. But it's one thing how we pay for it, it's another thing how we access it. So we have an issue with, even if everybody can access a healthcare system, it doesn't mean that we access it equitably, that everybody has the same access. It could be language, it could be culture, but more, I would say, if we look at data across Europe, it's actually education. That there is a fear among people who have less education that they are not, that they are doing something bad if they go to the doctor. Well, health equity is important in terms of the main thing that is important with health equity is that it relates to values of fairness and justice. So if we consider health to be a human right, which I think most people in public health do, it is important to see that it is the issue of fairness and justice which should be emphasized. That it's unfair, it's unjust if we cannot get everybody to have the same access to healthcare as everybody else. We'll skip this one, but basically health inequalities can be seen within or between countries or within countries. And wherever we look, there will be differences. Now, focusing a bit on health and education, because it's something that has been studied quite a bit. Why are well-educated people healthier than those who are not? First of all, healthy children can go to school, so that goes for healthy students as well. So it's important to keep young people healthy. That's one thing that is essential. But education, why is it a key determinant of health? Well, one thing is often said, and that is that educated people are better to process information regarding health. Now, that could be true when we're talking about quite intricate and difficult things to grasp. But most people, I would assume, know that the big killers should be avoided. We know that we shouldn't get too fat. We know that we shouldn't smoke. We know that we shouldn't drink. And everybody knows this. That's not what you learn when you get a degree at university. You learn that much earlier. So it has to be something else. And one thing that is important to understand is that the demand for health increases with education level. So that's another thing, that when you get educated, you seem to demand health more. Um, Now, what is it that drives this demand? And one theory, which I kind of adhere to, is that if you invest in yourself, meaning you choose to educate yourself, you want to maximize the benefit of that education. And that is to stay healthy. Because if I'm not healthy, I can't work with the job I trained years to become. So I think that's an important part of the puzzle. Another part of the puzzle is something called social stress. That we know that people who are at the very low end of the social spectrum in the country feel stressed because they want to get up there. And we also know that actually everybody has social stress. The middle class, so to speak, is quite stressed about not dropping down. And they are also a bit stressed because they want to get higher too. And the richest people, they are really stressed about not dropping down, of course, but also a bit worried that there should be more people who get rich. So social stress affects us, but it affects the ones on the bottom much more than the rest of society. So that's another explanation that has been brought forward. Gender is also an essential part of this puzzle, meaning, and especially if we look globally, where a lot of women don't have access to education and are not invested in by their communities. For example, in India or in China or wherever, where women are sometimes second-class citizens. So they don't even, a family won't even allow a young daughter to go to hospital because why? She's just a burden. So that's another important part of this. One way of addressing health inequality, which is important, is health literacy, and that is the degree to which individuals can obtain, process, understand, and communicate about health-related information needed to make informed health decisions. So when you go to the doctor, do you get what the doctor is telling you or not? Is it just you nod your head because you don't want to look stupid? Or do you actually get the information that the doctor is giving you? And that is also something, when we come to more complicated and more complex things, education definitely helps. So there is a need for healthcare to evolve health literacy, to become more patient oriented in some cases, to make sure that the patient understand that it's 2 pills per day, not just one, or that it's 2 pills per day for 10 days, not 1 pill whenever I feel like it for the next 4 days. So health literacy is important to alleviate some of the difference in health in the social determinant of education. Before we end, just going to give you a few names that are social scientists and so concepts in social science that have looked upon social determinants of health from a social science perspective, because often we talk about social determinants of health, we talk about it from a medical perspective. How can it explain why some people smoke, for example, those kind of reasonings. Here it's more, what kind of society are we building and what's the problem with that? So the French sociologist Pierre Bourdieu is a very important guy in this way, because he was both talking about the habitus, and that is um, how we from a young age are trained into a social setting to understand that social setting and interpret what goes on around us. So if you think about that first rainbow model, that's exactly what it actually describes. How whoever we are, with whatever genetic setup we have to interact with the world. And some of us are pressured harder and more by the things on top. And we are all affected by it. And how are we affected by that is what Pierre Bourdieu was looking at. He and also a political scientist called Robert Putnam were the fathers of the concept of social capital, which we was talking about before, about social networks and the value of those. Putnam was um, made a big study on comparing northern and southern Italy, where he pretty much showed that one of the main reasons why there were probably quite considerable differences in life expectancy between southern and northern Italy was because in northern Italy there was a higher trust both towards others but also towards institutions. You weren't afraid of other people, you embraced other people. Albert Bandura, psychologist, launched the social cognitive theory, which is pretty much helping us to understand how behaviors are learned. How do we learn to uh, behave in a way that is beneficial for us, for example, when it comes to health? Kimberley Williams Crenshaw, intersectionality, has also that concept, I would say, has been quite important because it and the for two reasons. One is power dynamics, that we understand through the lens of intersectionality that power is affecting people in many different ways. So, and depending on which intersection you belong to, when you are experiencing um, uh, different things, will affect how you relate to those things. Um, Now, Kimberly Williams Crenshaw was very much into the rights of Black women, etc., in the U.S. Um, but it doesn't only have to be a question about who are oppressed or not, even though I think she might disagree. But it's also about how we actually understand the world and how we communicate with each other around those things. Um, so in order to actually understand how we should develop healthcare systems, for example, we need to understand that there is not one type of patient. There are several types of patients. Um, and if the system should be able to service everyone, we need to understand that all of these types of patients need to interact with the system. And then finally, Frantz Fanon, if we talk about global health, post-colonialism is extremely important. It explains how, for example, the healthcare systems in Africa and India are designed. And what they were designed upon was the UK model. And the UK has one type of health system because it caters to UK health problems. It doesn't fit very well with southern India or Uganda. Um, you need different health systems. That's one thing. Another thing is also here power dynamics, of course, and understanding that the power of wealth that rich countries have in a global world will affect the way health can be distributed and produced in poor countries. For example, most of the clothes you're wearing are probably produced in Bangladesh or in Indonesia or somewhere in a not um, so great place, a sweatshop um, in a tropical Asian country. Now, we want this because we can afford the clothes. So that's one part of it. But and Bangladesh wants this as well because they need production, they need income, and this will create a solution. This will create a business that nobody really likes, and it creates a lot of health problems, etc., etc. But if we close our eyes and pretend it's raining, we can see the benefits of it. But we need to understand these global power dynamics in order to understand how we can improve the world we're living in from a health perspective. But there are other perspectives as well, of course. So with that, I would like to thank you. And if you have any questions, I'm happy to answer.
Thank you so much, Martin, for this very insightful presentation. And I would hereby like to encourage everyone who has questions to share them on the chat, and I will read them out to Professor Martin Stafström. And we actually do have a question in the chat, and I think it's regarding the poverty that you mentioned in regards of the healthcare. Because one of our viewers asked if does a long-term plan or strategy exist to increase the income of the third world population? What do you think about this?
No. Put it this way, there was a long-term plan 25, 30 years ago, mainly run by the IMF, International Monetary Fund, and the World Bank, based pretty much on neoliberal ideas. But I would say that in the past decade, that perspective has been pretty much criticized. I know several Hungarian people who are not too happy about it. So I think, and the main problem, as I showed in that slide, it's not only about money. It's not only about getting money into a country. You need more than that. A society is not only built on the money there is. Money has to be distributed to start with, but you have to invest in the right stuff. We could have a country where everybody is running or driving Teslas, but they're dying at age 35 because nobody cares about healthcare. So I think there used to be a plan. That plan was criticized, and now there is an ongoing discussion on what should the plan be. I should also point out that I think there has been quite a shift also in the past years where money is probably not the one thing we're talking about when it comes to global development. Sustainability is starting to take off as being as important or even more important, with the whole climate crisis hovering over global development.
Okay, thank you. We also have another question, which is actually a problem that I see in my acquaintances quite a lot, that people tend to go to the doctor too late when they actually have an existing problem and not as a preventional effort. So is there a good way to open up their eyes to be more forward thinking?
I don't think there is a magic bullet regarding that. I mean, I think there is in theory to have primary health care close to the citizens with good access. Don't have people running to hospitals all the time. Let's go to the GP at the primary healthcare unit. But I think it's a problem both with human resources and having this. I mean, resource allocation in healthcare is a big issue. Where should we put the resources? And if we want a high-tech diagnosis unit, we put it in a hospital with all the latest technique and stuff, and it costs zillions of euros. But it's something the politicians love to show. And whereas having a few more GPs is not as flashy and nice and cool. So I think that's one issue. The other issue is, of course, that doctors don't want to become GPs. They want to be that flashy surgeon or whatever. And they don't want to live in the countryside. They want to live in the big city with working at the nice hospital and so forth. So I think the whole, in theory, get healthcare out in communities, make it accessible, make it into something that should be okay to go to your doctor once a year just for checkup. But people don't do it because it's not that easy in reality.
Great. Thank you for your answer. And we actually do have a third question, which is in regards of the before mentioned health literacy. Is self-diagnosis via internet considered to be health literacy, or is it actually, in fact, more harmful?
I didn't get the question.
So I think what the questioner means is that self-diagnosis via internet,
Yeah.
is it actually helpful in case of health literacy, or is it actually causes more issues?
Well, when I talk to my GP friends, they say that internet is their worst enemy. Uh, they see a patient and the patient is telling them that they have this unique cancer that is detected in 1 in 12 million per year. Um, and they are spending the entire time trying to convince the patient that no, it's just the flu. um, I think internet can be useful. I think it's important that internet that there is some kind of quality assurance to the internet resources that you use. I think it's important that internet, if we take healthcare systems, national healthcare systems, that when they provide information online, that they also provide some kind of phone service or something that, because of course when you get sick, most people are alarmists. They deduct that the worst thing will happen to them. But I think that's that's one big challenge with this. That I think there could be instances where it's probably good, but it also creates quite a lot of harm to the system. Nobody dies from learning about this, but it swallows resources.
That makes sense. So in the end term, I guess. Oh,
But
sorry.
one thing, for example, that I think could be useful, but very few uses online services regarding drug treatments, for example. But if you are handed a drug, I think everybody should go to the website, depending on where you are, and read the information about the drug and the therapies that are usually prescribed, etc. So they understand that it's not only the doctor who said that you need antibiotics for 10 days, not for 3 or whatever it might be.
Okay. Thank you so much for the answer. For now, I don't see any other questions from our audience. So if that is the case, then I guess we can wrap up today's session. So once again, I would like to thank Martin Stafström for holding his presentation today for us, and we hope that you are going to be joining us next week for our session, which will be titled Environmental Determinants of Health. So with that in mind, I would like to wish everyone a pleasant evening, and goodbye.